Okay. Hello, everyone. Thank you so much for your interest in today's Health Technical Learning Lab webinar. My name is Emily Hirata, and I'm the chair of the Health Technical Learning Lab, or the HTLL. And today's webinar is on community action groups for augmenting community engagement in vaccination based on activities with ADRA India. ADRA India has implemented one of the longest public health programs in India, supported by USAID and Core Group. Core Group Polio Project, or now referred to as Core Group Partners Project, CGPP for short, was launched in 1999 to implement the USAID-funded Polio Eradication Initiative. ADRA India has been a partner with CGPP since 1999. The project has played a pivotal role in addressing public health challenges in India with a primary focus on polio eradication, routine immunization, and recently COVID-19 response. ADRA has supported the government-led immunization program in Uttar Pradesh and Assam. Recently, with support from Population Council and other core group partners, ADRA conducted a study on the motivation and scalability scope of engaging community volunteers, known as community action groups, for public health intervention. To present today's webinar on this topic, we have Shilpi Das, Senior Manager for Program Operations and Strategy at ADRA India, and Vivekananda Bishwash, Program Manager at ADRA India. As we stroll through today's webinar, please be sure to place any of your questions into the chat, not the Q&A. Please put it in the chat, and we will try to get to as many of them today as possible after the webinar. It is a small group, so I do encourage your participation. Any questions you have, please post them. And thank you so much again for being here. We will have some more follow-up after the Q&A on next steps. But for now, Shilpi and Vivek, the time is yours.
Thank you, Emily. Good morning, good afternoon, and evening, everyone. Thank you for your time and interest for the webinar. Today, we present a study that was undertaken in partnership with Population Council Core Group Partners Project, and which was supported by USAID. The Core Group Partners Project, basically, we are 3 PVOs, PCIs, and ADRA India. So the study basically aims to explore factors influencing motivation, supportive supervision mechanism, and overall scalability of the community action group model. The study will further evaluate the potential for replicating the model to different geography. Next slide, please, Vivek. Vivek, next slide, please. Vivek, are you there?
Yeah. Is it visible?
Nope. It's not visible to me. Emily, is it visible to you, the second slide?
No, it is not.
I think there is a technical glitch. Can you try again, Vivek?
Yeah, sure.
Sorry for that.
Is it visible now?
It's visible, but it's the third slide, I think. So in the meantime, I will, while Vivek displays the slide, I will just go through the presentation. Yeah, this is the second slide, Vivek. So in India, the polio virus was a significant public health challenge that basically threatened the lives of millions of children and hindering to achieve the full immunization by the government. So in 1999, the Polio Eradication Initiative that was funded by USAID was implemented through CGPP and was initiated in the high-risk countries, and India was one of them. In India, we have implemented the project in 3 districts of Uttar Pradesh, a difficult area in Uttar Pradesh, high-risk area, and also in Assam. The project implemented through various partners employed a community-centric strategy. Yeah, it is visible now. Thank you, Vivek. So the project implemented through various partners basically employed a community-centric strategy with a focus on enhancing local capacity. And it adopted a multi-pronged and community-based approach to identify and engage community influencers to counter misinformation and misconception associated with the vaccination. So basically, the strategy included a thorough process of mapping influencers, identifying community leaders, and influence over vaccine-resistant families. The influencers were sensitized about polio basically, and social mobilization and engaged to mobilize resistant families using social behavior communication tools to counter misinformation and misconception. So basically, these influencers played a crucial role in supporting the vaccination campaign and building trust within the resistant community, thus serving a bridge between the community and the public health system. Next slide, please.
I think due
Yeah.
to net connectivity is coming. Yeah.
So the study objective of the study is basically three basic objective: to document the profile of the community action group members and their motivation for such volunteer works, like why were these community workers who were not paid were engaged in this community action group, what was the motivation. So this was one of the objective of the study, to understand the motivation factor of the community action group. Also to capture the stakeholder perspective. The stakeholder here in this particular study are mostly the healthcare workers, the healthcare officials, because this was more of vaccination. So what did the stakeholder perspective, what was the stakeholder perspective about the CAG intervention and their functioning? And the last objective was to assess the scalability and replicability of the CAG innovation in other geographic location and contexts. And to certain extent, we think that this was a success because UP, yeah, ADRA and core group were working for a long time, but Assam was a new area, new state for us. But despite a new geography, the CAG members were formed there as well, and they were working very well as similar to the UP. So I think the scalability and replicability of the CAG innovations can be spread across other locations as well. Next slide, please. So the methodology, basically, given the scope and objective of the study, a descriptive study design was basically adopted to achieve the research objective. The study was used a cross-sectional mixed method research design that basically enabled the study to comprehensively understand and document the journey of the CAG. Through the mixed method research approach, the study had done a rapid literature review. The literature reviewed had both qualitative and quantitative studies published that explored the factors influencing motivation for community-based work across South Asian countries through various journals. So basically the literature research was mostly concentrated to the South Asia region voluntary work research. Through the secondary data analysis, the project had a strong MIS. Since last 20 years, this project had a very strong MIS system. And the particular study tried to study the MIS. Through this MIS, the CAG member profiling, including age and occupations, were studied. The profiling of the CAG members were conducted across 1,228 villages covering 3 states, namely Uttar Pradesh, Assam, and Nuh in Haryana. So for the qualitative data, the study adopted for an in-depth exploration basically of components such as group formation, determinants of motivation, the existing mechanism for support, relevance of CAG, community acceptance, and potential scalability. And the qualitative data, there were a number of interviews undertaken with FGDs, the focus group discussions. Post-FGD surveys were undertaken. Community members were individually interacted and surveyed. There were also in-depth interviews with community stakeholders. When we say community stakeholders, it was like the community members, the ration worker, the barbers, so anyone from the community, the mullah. So everyone who was there were there in the in-depth interviews. And also the key informant basically were also there from the government officials. So basically, through the rapid literature review, the secondary data analysis and the qualitative data. So this whole methodology was done. And post this, a co-learning workshop with 22 CAG members and program implementers like the DMC, the BMC, the program managers were also there to validate the study finding and recommendation and capture the context variation. Next slide, Vivek. Thank you. So this particular slide depicts the context of the emergence of the CAG, basically the community action group and its vision. The outbreak of COVID-19 pandemic marked a significant turning point for the global community across. And the marginalized communities especially were particularly affected as government services and development programs came to a halt. The vaccine initiative basically faced hurdles due to hesitancy and resistance filled by misinformation and rumors. There was a lot of challenges for the in the health sector, and a vacuum was created. Basically, there was a vacuum, a broken link between the community and health service providers. And this particular situation basically prompted the project to engage the community influencers into groups known as the community action group. So if you ask, the community action group was formed during the COVID time. Even though the community influencers were there since last 20 years throughout the project history, but they were working in silo or individually. But the group formation had started during the pandemic time or the COVID time. So the rationale for forming the group was based on the principle of group ownership. The principle that was rooted, the idea that when influence, like basically the influence was collective, own and participated in decision making regarding community read. So it fosters a sense of basically responsibility and accountability. And hence, the vision of the CAG is envisioned as a group of trained community influencers. So these CAG who were formed were trained community influencers who could be leveraged and activated by the health system when required. So these CAG members were capacitated community groups and strengthened the work of health functionaries in improving the community update of health services by bridging the gap between the health service and the community. And some of the critical characteristics of the CAG were very interesting. These CAG members, most of them, the CAG members were found to have group ownership. They had the collective decision making. They were accountable. When you ask about the strength of the CAG members, they were local influential. So it was anyone, a Panchayati Raj member or the SAG member, but they had some kind of influence, local influence at the village level. They were also somehow connected to religious authority or political, some of them. Departmental linkages were strong in the volunteers, and knowledge of the community, in-depth knowledge of the community was seen among the volunteers. And some of the traits, not everyone could be an influencer or everyone could be a CAG member, but there had to be some traits. One of the traits very important was the selflessness, the desire to contribute to social welfare. When someone is working without any money, without any opportunity, so there is the selflessness, the desire to contribute to the social welfare. Communication skills was something they had most of the time, and availability of time also. Like maybe someone has a desire, but they were not available. If they were migrant, it was difficult for them to give the time. So availability of the time was also some of the characteristics of the CAG member. So this particular slide will show like the CAG structure, basically understands the CAG structure, which is uniform across the states, the 3 states, but there was certain contextualized approach also undertaken. So the CAG members were a mixed group with representation from diverse social identity, basically religious authority and government department on voluntary basis. Inclusion of diverse gender and religious minority was a crucial consideration for made at the time of formation of CAG. So a mixed gender group was there. The CAG usually were a small group size, basically 7 to 8 members to prevent a group dynamic, basically. And the study also reveals that the CAG member were from diverse backgrounds, such as a farmer, ration dealer, ASHA worker, local doctor. So you can see all the names in this particular box, the pradhan, the laborers. So it could be anyone. It's not that there was only the political person or an influential person, but it could be anyone who had the commitment to work for the community were part of the CAG member. So basically in Assam also, the context was almost similar, but since this was tea garden states of Assam and they were private states, so approval was sought from the tea state management first, and there are welfare departments there who knows in and out of the tea garden. So support was taken from the welfare officer consulted to identify the community influences. Next slide, please. Thank you. So this particular slide mentions about the CAG members, what was the training need, how were they trained, how were they oriented. So orientation were conducted during the monthly CAG meeting by the BMCs. When we say BMC, it is the block mobilizers, basically the mobilization mitras who they were our staff, the CGPP staff, basically. And orientationally mostly covered health issues and were guided by health system needs such as measles, dengue, malaria. So basically, for example, the capacity building of CAG members were context driven also. In the previous slide, I have mentioned about context driven. So rather than following a predefined structure. So for example, if it's a malaria endemic area, then the CAG members were trained about malaria prevention as well. So, and some of the CAG members, not necessarily were all trained by our staff. Some were trained by a stakeholder like MOIC, the medical officers. The CAG members were usually given IEC materials for reference, so that was easy for them to speak to others when they are talking about rumors and how to mitigate them. And through this, the CAG visibility has increased. Community members reached out to CAG for support. So, but the orientation of CAG were ongoing process, and the project staff and stakeholder conducted the training. And it was important that monthly meetings strengthen the CAG motivation. The project we have just closed the project recently, but while closing out the project, we have handed over the operation guideline of the CAG to the stakeholder, the government functionaries. And so now it is up to the government functionaries how the MOIC will be training or orienting the CAG on a monthly basis or a quarterly basis. Yeah. Thank you. Next. So one of the objective, as I mentioned, the first objective was to find the enablers of motivation among the CAG members. What motivated them basically? So based on analysis of qualitative data and interaction with CAG members, the key finding included like high sense of pride. The CAG member felt pride and inspiration from these affiliations, like the government affiliations, the recognition which they were getting, basically. So high motivation towards voluntary work observed among the CAG members. Factors that contributed to motivation were learning opportunity. They got to learn new things, new diseases, about the community, how to improve the community. So the learning opportunities they were getting was a motivation for them. The support they were receiving from the fellow members and the program staff were also some of a kind of motivation. The felicitation by government was very important. The recognition, even though the felicitation is there, but the recognition, a medical officer, a district commissioner, when mentioning about the CAG member, individually naming one of the CAG member was a high pride. So they felt pride in that. So that particular thing motivated them a lot. The community recognition, people understood that, okay, they are a member of the community, the CAG member, and the community recognized them. So one of the important finding through this study was that it was necessary that the government felicitates and motivates the CAG member for maintaining the motivation. Next slide, please. Vivek, next slide.
Yeah, I already changed.
Yeah, I think there is some technical hitch here. Yeah. So the CAG brought additional value to the health system. This was something which was not us, the project staff talking, or the community members talking, but this was something which the government officials were saying. So the government official mentioned that the community influencers were far more effective than the effort of individual ASHA workers sometimes. So the stakeholders, specifically health functionaries, highlighted the relevance and value of the CAG in bridging the gap between the health system and community, ensuring last mile delivery of the health program. And the value of CAG was attributed to their composition of influential members, because many of the CAG members were influential members with deep community knowledge, understanding, and also the departmental linkages. The community trust in CAG was based on social positioning of the CAG member, the social work during the COVID-19. Most of the CAG members were somehow doing social service or volunteer work during the COVID-19. They were easy to approach. They were very easy to, even though they were influential, they had departmental linkages, but they were easy to approach, and they could provide timely support. So, however, the community knew individually, but there were certain areas, certain pocket where the community still didn't knew about, like the community, the CAG existence. So that was one of the challenge which the project were facing in certain areas. Yeah. Next slide, please. So for the sustainability and replicability of the study and of the model, basically, I would request Vivek, my colleague, to please hand over and take it over here, because he is with the project since long, and he will be in a better position to let us know about the sustainability and replicability of the structure. Over to you, Vivek. Thank you.
Yeah, thank you. Thank you so much, Dr. Silpi. And am I audible?
Yes, Vivek, I can hear you.
Okay, so I'll put off my video to ensure that there is no connectivity issue. Yes, so as the Dr. Silpi said in the beginning, that the influencers in the polio program, they were since the beginning. For last 20 years, they are working with us. And the COVID-19 pandemic gave us an opportunity to bring all these influencers under the common umbrella of community action groups. Before we formed the community action groups, they were working individually for the particular area. But the need was found during the COVID-19 that there was so much fear, so much health issues suddenly came in the society, and we felt the need that all the influencers would work together, and actually basically they took the lead. And this model we implemented for last since 2020 we implemented, and the biggest question for us was its sustainability and scalability. So our study focused, we had a dedicated section in our study to identify the scalability or the sustainability of this model. So we asked particular questions to the community action group members, to the government stakeholders and other stakeholders, to all the community and many of the community members about the sustainability part, that whether this model will sustainable and why they think so. The good thing is that we found in our study that majority of the respondents, they think that the CAG is very much sustainable. The CAG model is very much sustainable due to its composition. As we said, that the CAG is a representation from the entire community, starting from the local doctors, education department, health department, social workers, and so it represents, from the each part of the community, each corner of the community. That is why So this is one of the component. Because of its composition itself, it's a very much sustainable. And also this project, through this project, we have established a linkage between the CAG and health system. Like we have shared the detail of the CAG members with the health department. So whenever there is a need, there is some issues. So the health department and also from the CAG members, so they can directly communicate with each other and they can bridge the gaps between the service provider and service delivery. Then the inclusion of the community action group members' name in the microplan. In India, we have a very robust microplan system. It started for this polio program, but now we have adopted it for all the public health program. And in that microplan, the CAG members' name are included, that for a particular area, who is the local influencers, who is the CAG members, and what kind of support they can provide. All these details are included in the microplan. Another component under this sustainability, what this project has done, what we have done, that we use IEC materials or banners, particularly if we talk of the banner for different campaigns, different health programs, and even in the village level. So we have dedicated a wall. It's called a CAG members wall, and we have putting their names in the banners and in that particular wall at the common sites, so that the villagers could identify, villagers could know that who are the CAG members in their area, and they can have a conversation between them for any kind of issues. Another factors that can contribute to the sustainability is that regular orientation sessions. So far, that we had our block level staff, our district level staff, they used to visit and they used to orient them regularly. But now we have moved out from that program, that we have closed the CGPP, and before moving out, we have withdrawn our block level and district level staff. So to bridge that gap, we have established and linked that who will take part of that role in place of like block level staff, district level staff. We have identified the available person at the government structure, and we have handed over those roles to them so that the regular orientation session could take place at the village level with the CAG members. Then felicitation is another component, felicitation of CAG members, because when we tried to find out because these CAG members, that they are not getting any monetary support or nothing, because they are providing their support voluntarily. So this is purely volunteer service. And one of our challenge was to see, because so far we have heard that volunteerism do not work, but we are proudly through this study, probably we can change that perception, because we have seen that this volunteerism is working now. And one of the most critical component is the felicitation of the CAG members for their motivation, because whatever they are doing for their own community, own village. And for that, a little motivation, a little recognition or felicitation is a huge thing for them. So time to time, like we have 3-tier Panchayati Raj system, local civil government. So whenever there is an opportunity, they are getting recognized, they are getting felicitated by this kind of local self-government or the health system, health department, or the district magistrate. Also, we have provided identity card, and we are trying to advocacy with the government so that this kind of identity card could be given or it could be a actually providing an identity card gives them kind of a recognition as well as identity. So this is one of the important factors what we found that could contribute to the sustainability part, and also participation of the CAG members in the various available platform, including them in the various available platform. Like in India, we have many platforms. Like every month we are having meeting with the Village Health Sanitation and Nutrition Committee. In short, we call them the VHSNCs, Village Health Sanitation and Nutrition Committee meeting. Every month it is happening. 3A coordination meeting. We have our Anganwadi workers, ANM and ASA workers. They are the frontline health workers. So these three type of scatter, they are meeting every month. And whenever this type of meetings are happening in the field level, we have ensured that the CAG members also get a call and they could be a part of that meeting also. And yes, there is a challenge. We have also identified what are the possible reasons that this model could collapse. So the government officials, they fear the losing communication channels, because this is very important, communication channel between the government officials and the CAG members. If this communication channels are break, then maybe that or like as I said, that we have withdrawn our internal staff, and there is high chance that these communication channels are break. So then maybe this model could get collapsed. And also, as I said, that recognition, like small sort of recognition is a huge for the huge motivation for the community action groups. So those kind of activities on the part of the government side, if these are not taken place, then maybe this model could collapse. So now the next slides, I'll talk about a little bit the scalability. Yes. So as Dr. Silpi said, that initially started it in the Uttar Pradesh, and we have replicated it in the Assam also. Like the health department particularly recognizes the community influencers approach, that some of the key consideration are that this is very much essential, that some sort of government order for formation of the community action groups. If the government take this initiative, like and some sort of order is released by the government part, that initiation is taken from the government part for the CAG formation. So it will help for the further replication in the other areas also. And a clear guideline is also very much necessary, that how to set up the CAG, and who will be the members, and all mentioning all these details. A clear guidelines need to be developed. And through CGPP, yes, we have developed a detailed SOP for that, and we have shared with the government, so that they can, if they want, they can replicate that in other areas also. And identification and selection of the right community influencer is very much essential. So this part actually very, very crucial, and that should be done at the beginning, even before formation, that identification, because there could be many influencers, but who could we devote some time, and who has that kind of motivation. So that identification is very much essential, and for that involvement of the frontline health workers is much needed, because they are the key workers who can identify the right person. And then, yes, of course, as I said, like in this project also, so we have established a linkage between the local community and the health department. Until and unless this linkage is established, we don't feel that this model would sustainable. And of course, that in terms of scalability also, there is no questions of scalability. So in summary, if the CAGs are to be formed in new geographies, it should be ensured that they are inclusive and represent the composition of the areas of program implemented. So there are some key consideration, like already I said. So this is also again, if I summarize these 2 points about the sustainability and scalability, the first thing is identification and selection of the right person in collaboration with multiple stakeholders, involving the local frontline health workers, and also establishing a strong linkage with the local communities and health department. Then next one is the building community ownership and motivation among CAG members. That may be a challenge, but once this first point, that linkage and this communication is there, communication between the health department and the CAG members, that challenge could be overcome easily. And as I said, that the detailed SOP is very much required. The need for a clear guidelines informing the CAG setup, who will do what, and how frequently they will meet, and what kind of discussion will happen, and of course, time to time orientation, because these influencers may not be aware about the government health programs or their need and to whom they should approach. So at the beginning, this kind of orientation is very much needed. Then intervention strategy in the new geographies must be evidence-backed. Like what are the strategies, what are the intervention, and what are the purpose of this formation of CAGs? That has to be very clear, and there has to be a mechanism of acceptance and recognition of these community influencers through the health department and also through the other administrative departments. Then CAG activities should be monitored, as that is a disabling factor, because if nobody asks, if nobody monitor, so that is why we said, because whenever when we had our project, we had our internal staff, but we have ensured. So this is a critical area. We started working this handover process. We started working 2 years back. So once the project staff is withdrawn, there has to be someone from the health department who will monitor, or if not, at least who will mentor them. So this regular monitoring and mentoring mechanism is very much essential. And also the district mobilization coordinator, that is the district level staff, and the block mobilization coordinators, or someone from the health department need to be there to guide the CAG members and to set up the functioning of CAGs for the initial years. So once the setup is done, so this approach or this model is very much workable. And as of now, what we have experienced, it is very much sustainable and it is scalable. So my last slide is that key takeaways. So we have few key takeaways. The first one is the CAG comprises influencers who are already linked with various government departments. So strong advocacy is very much required, so that the multiple government departments can tap the potential of such groups. They know that who are the CAG members, what kind of role they can play, and how they can bridge the gap between the service provider and the service receivers. Second one is develop a clear guidelines for the setup of CAG with the scope, for contextualization at the district level. And the last one, again, our study says that advocacy with the relevant departments can be done for the felicitation of the CAG members. So repeatedly I said during my presentation that yes, this felicitation recognition is one of the key component, so which can boost their motivation to engage in various community level activities. So thank you very much. So would be happy to take if there is any questions. And over to you, Emily.
Thank you so much, Shilpi and Vivek. That was a very enlightening presentation and very interesting findings. I would now like to direct us over to the chat. We do have a few minutes before we close, about 14 minutes or so. So I'm just going to get us right into it. We won't be able to answer everything, unfortunately, but we will try to get through a few questions at least. So to start us off, is there evidence that the CAG strategy does positively impact the immunization rates?
Yeah, Vivek, if I'll answer to that question and you may join in. So there is evidence, but it is very difficult to say that only one criteria, the CAG members increases the immunization rate, because there are other factors also which are associated with increasing the rate of vaccination. It's a difficult question, I'll say, because this is not only a single criteria where we can really analyze about because there is demand side problem, supply side problem. So I don't think it's we will be able to answer that correctly, like what evidence we have right now. Yeah.
Yeah, yes, Dr. Silpi, you are very right. I just add one thing. Yes, in terms of, mobilizing the vaccine hesitant families, in terms of saying that increasing the vaccination rate, yeah, of course, there is evidence that vaccination rate has increased, but as Dr. Silpi said, we cannot directly demand for this CAG model, the vaccination rate has increased, but yes, in the like CGPP or wherever we are working and wherever we have implemented this model, this is the hard to reach area or the problematic area where the vaccine hesitancy was very, very high compared to the other areas. So in this particular area, that vaccine hesitancy drastically dropped down, and we have an evidence like recently we have implemented this model in Assam and UP, where the zero dose children, when we started, it was more than 7%. And after introducing this model, within 9 months period of time, that zero dose was reduced to below 1%. So that kind of evidence we have. Yeah. Thank you.
Other continents that volunteer groups generally are not sustainable after the project ends. How did we determine sustainability, particularly after the project funding ends? There was a response in the chat, but I also want to give our presenters a chance to respond to this.
Yeah, so we are not claiming that this is a sustainable as of now. So this is a study which is trying to understand if the project can be sustainable, and there are certain consideration which were given or recommendation which were given through this study. So some of the recommendation was government ownership. The ownership of the government. Once the project ends, the government should be taking the ownership. So this is a study which is done recently, and we don't have an clear understanding about how it will take place in the next year. Maybe once we again do a study next year, we will get a clear picture. But there are certain recommendations which were given through this study, and one of the key recommendation was government ownership. Giving an identity card by the government to the CAG member will bring more ownership and accountability to this particular and have a sustainability plan.
Thank you, Shilpi. I have another one which also has a response in the chat, but I do want to give you a chance to respond as well. Is the overall culture of UP and Assam already respectful and supportive of the health system, of volunteering for the betterment of one's community? I'm wondering if there are overall cultural facilitating factors that contributes to the sustainability of CAGs.
Vivek, would you like to respond to that?
So sorry, can you repeat the questions?
Yes. So the question is the overall culture of UP and Assam already respectful and supportive of the health system, of volunteering for the betterment of one's community?
Yeah, so no, it was not like that. You know, when we started initially, that in UP and Assam, this we had, like in UP and Assam, there are, UP is the another state, another cultural context, and Assam we have another cultural context. Even it was not always respectful, but yes, throughout the when we started working in UP and Assam, so there are two things. We had some component for the community people, for at the community level, and also we have worked a lot for the service provider. So it's not like that they are easily accepted, or you know. So what I would like to add, that if we really want to implement this model in some other areas also, so we have to have this clear strategy for at the both level, for the community level also and for the service provider level also. In the both way, so this cultural context, we can establish a better relation between both the, you know, for the community members, for the CAG members, and with the health department. I'm not sure if this answered the questions, but yeah.
Thank you, Vivek. Yes, I think it did. Let's move on. There's an interesting question here about selflessness and commitment. How were selflessness and commitment measured to decide if the individual influencers were eligible to be in the CAG?
It was not decided, but basically when the CAG members were selected, some of the criteria were they had to be doing some voluntary work in the past. So they were already working as a community influencers in the past. So they had that trait of selflessness in them. So certain traits were there, like the voluntary, the influential trait, like easy to approach. So I think in my third or fourth slide, I have mentioned about certain traits which were there. So it was during the selection of the CAG members, we did not access, and there were many dropouts also. It's not that the group, once group were formed, everyone was still maintaining that CAG group. There were certain dropouts, and when there was dropout, new members also joined in. And here I would also like to say that it's not that all the CAG members are performing the same way. There are certain high and lows in between the CAG members themselves also. So yeah, to answer to you, I think this was not accessed at the time of hiring, but yes, the voluntary, their experience was voluntary work, influential, these kind of things were assessed while they were hiring.
Yeah, just I'll add one more point, Dr. Silpi. And as I said that at the time of hiring, this is very much essential that we involve the local frontline health workers, because they know the health behavior of the community, and the community's health seeking behavior actually reflect the influencers, you know, who are easily available, who are accessible, and like for example, who to whom the community approach very fast. Is it the local doctor? Is it the religious leader? So by this way, to some extent, yes, can identify. Yeah, thank you.
Thanks, Shilpi and Vivek. Related to that question, we have another one about recruitment and formation. How exactly were the CAGs recruited and formed, and how did the team bring together the influencers?
Yeah, so let me answer this question.
Yeah, sure.
Yes. As we said that we already at the beginning, we had our identified influencers who were actually working for the community, uh, particularly for polio or routine immunization. So in a community, there are 5 scattered area or 5 lanes or 5 different divisions. So there was 5 influencers were working in these 5 areas separately. But when COVID pandemic came, so all these 5 influencers came together and approached us. And on the other side, we also approached them, and we sat together, and then we discussed the need of the community. And this concept was came up that how about if we can work together rather than working individually, because different component we can add on in that way. Like if if we if you recall that composition what we shared, there is a local doctors, so that any kind of medical support they can give. And in the particular in the COVID time, we have seen that people had no food. So we had the food department representative, what in India we call ration dealer. So we included them also. Then we had local health service provider from the government part, like ANM and ASA workers. We included them. There was some myth or misconception. So we had religious leader to handle those. So when we talk, after identifying the influencers from the different sectors of the community, then uh, it's not like that something was imposed, but yes, the concept was we actually ask them that what if we can work together in this way, if we form a uh, if we come together under a common umbrella, so that everybody could know what is their capacity and how much they can help. So like this, actually we included everyone. And I must say that yes, concept was uh, percolated from our end, but rest of the things, that acceptance and how they'll work, what will be the norms, how frequently they will meet, everything came from the community action groups. So once you go with your idea in the community, we have seen in both the states, even not only in UP and Assam, we had also another partners who are working in Haryana and other states. So from everywhere, we are getting similar kind of response. Thank you.
Thank you, Vivek. Unfortunately, we won't be able to get to the rest of our questions because we only have a couple minutes left, but I do want to thank our presenters, Vivek and Shilpi. Thank you so much for what you have shared with us today. This is really, really interesting and very exciting findings. So thank you so much for sharing with us. And thank you to all of you who have joined us today. Please be on the lookout for a follow-up email with a recording of the webinar as well as a short post-webinar survey. Those surveys always help us out for doing new webinars in the future. So please fill that out if you can. Our speakers have agreed to provide answers to any unanswered questions. So those answers will be included in the follow-up email as well. So just be looking out for that. And yes, I guess that's all for today. Thank you so much for joining us, and please join us again next time for another HTLL webinar. Bye-bye, everyone.
Thank you.